Hello, everyone. We're here at the end. My name is Dominique. I'm an associate professor at NHS, and we're doing multiple layers of introductions here because we're actually very excited to have Michael Orsini as a Fulbright scholar spending a semester with us at NHS from the Department of Political Science at the University of Ottawa. So I'm going to let him give the introductions, actually, and I will be the evil timekeeper. We're going to try to keep to about 7, maximum 8 minutes, so we have time for questions.
Okay, so we're going to lead off with Joseph Interrante. Is that? I'm not sure if
that was much more exotic than usual.
Okay, sorry, I'm Italian.
Good.
Who's going to be speaking on the politics of HIV/AIDS in the South. He's from Nashville Cares.
And all right, I'm technological aspects. Like, how do we work this?
You're loaded. Just hit down.
We're back.
Because of the thing.
Yeah, we're back. No, that's going forward. No, you're not at all. Who knows technology?
Yeah.
Blind leading the deaf.
I won't try in that case.
I don't know what
The actual, yeah.
So that's going to be just. Right. So what do I hit to just move to the next slide? Okay.
For this report.
So where is it?
It's coming.
Yeah, this is.
Okay. All right. Well, this is a my talk. This is very sketchy because it started at 20 minutes as it's been shaved down to 7. So I'm going to, but fortunately I can save a little time because I want to show you a couple of maps to start. And you've just seen the first one of these maps, which is the rates of people living with HIV in the South. The darker colors indicate the higher rates of HIV. And you can see that arc that runs from really Southern Virginia, North Carolina, down through the South into East Texas. The second map is a map that recently the CDC published on the lifetime risk of becoming infected with HIV by state. And again, as you can see, with the exception of New York and New Jersey, all the states with the highest lifetime risk are in the South. What these both indicate in a nutshell is that the South bears a disproportionate burden of HIV in the United States, whether you were looking at the total number of people who were diagnosed by year or the rates of diagnosis. And the South is indicated by the red and those Kelly green lines and bars. So we're currently accounting for more than 50% of infections. The South also bears a disproportionate burden of AIDS diagnoses, both in terms of the number of people who are progressing to AIDS because of a variety of reasons for not gaining adequate access, or people who are being diagnosed late, which means that they're diagnosed with AIDS and HIV infection simultaneously or develop AIDS within 1 year of infection. And not unrelated to that, we also have the highest rates of death. While deaths related to HIV have declined throughout the United States, they have declined more slowly, or less in the South. There were 29,000 deaths in the South in, I think it was 2013, and those were 43% of all the deaths in the U.S. 15% of those people who were diagnosed in certain southern states are dying within 5 years of diagnosis. Now, actually this shows you actually that first slide with a different sort of slide from the one you saw in the last presentation on rates of poverty, and you can see the correspondence in terms of the darker colors of the higher rates of poverty along with the higher rates of HIV infection. For that, okay, and okay. Sorry. So it's not insignificant then that in fact the South has some of the narrowest traditional Medicaid programs in the country, where in fact eligibility by income caps are much lower than the poverty level, and in fact non-disabled childless adults have practically no access to Medicaid in southern states compared to other countries, other states. And you know, that makes it particularly significant that the South is really behind, really part of the Midwest are really the two holdouts in terms of Medicaid expansion under the Affordable Care Act. In fact, that's interesting, just as a political sidelight. If you superimpose this map over the states that went for Romney in 2012, there's a pretty sharp, strong correspondence between the two. Now, one response to this is programmatic, and that has been, at least for HIV, the use of some federal funding that's available for HIV called Brian White to enroll people into the insurance exchanges, which all states have, whether they are federally managed or state managed. And the state has done better here, even though there are a greater number of states that have only provided limited access through these programs, either only by paying for premiums or by paying for co-pays, which really doesn't make a lot of sense. But they do help to address the Medicaid gap in southern states. One example of that is just here in Tennessee. Nashville has a partnership with the state of Tennessee. We've been actually running it for about 15 years, which started by helping people not lose COBRA. But when the ACA came along, we developed a plan with our state health department to enroll people, initially people who were eligible for subsidies, into the marketplace, and then most recently doing what we call a de facto Medicaid, including people under 100% of poverty who otherwise would be eligible for Medicaid if we had an expanded program. And as a result of that, we've actually tripled enrollment in the program, so we're now covering 4,000 people with HIV. There are a number of challenges to this. Because it's Ryan White funding for HIV services, it only covers people who are actually HIV positive. And as you heard earlier in one of the earlier presentations, that raises challenges even within HIV and AIDS, since with the advent of biomedical prevention strategies, PrEP, for example, providing access for people who are HIV negative becomes very important. So really, to avoid AIDS exceptionalism, we were working with other coalitions to try to get Medicaid expansion in Tennessee, though there are also challenges to that. Simply, in many cases, Medicaid expansion programs themselves have a more limited benefits package than many of these insurance packages. So part of the challenge that Louisiana, for example, is currently facing as they move under the new governor from this approach to Medicaid expansion is that many people with HIV are going to actually lose coverage for some of the benefits that they currently have because their Medicaid program is narrower than the insurance exchanges. On the other hand, we're now dealing with an increasing trend of the QHPs under the marketplace developing a whole range of practices that limit access, moving to co-insurance, increasing co-pays, increasing all kinds of barriers to access on the formularies, which is a problem. The other response is policy. I don't know if I can go back to that. I'm not sure when the other pictures aren't showing up, but there are a number of organizations, regional organizations that advocate on behalf of the South, Southern AIDS Coalition, Southern AIDS Strategy Initiative, and in Tennessee, the Tennessee AIDS Advocacy Network. There are a number of different policies, both statewide, within the states and across states in the region that we advocate for, which are listed here. I will say that politically, all of us working in the South face a number of challenges. One, as you've already heard, an extraordinarily conservative political culture in many states, like in Tennessee, with GOP supermajorities, as a result of very strategic redistricting in 2010. The paradox here is that, like in the House of Representatives, they did such a good job of redistricting that, in fact, state legislative leaders have often lost control over some of their caucuses, so it becomes doubly difficult to affect change. Also, regardless of party affiliation, legislators tend to be fiscally conservative, which creates barriers to change. There is a very strong social issue conservatism, which you heard about in the last panel, which I would also add is now wrapped in a new narrative of religious victimization in which the victims are moved from, for example, LGBT people to religious individuals. So you get a lot of religious freedom bills that are now in legislators. And of course, the influence of a lot of conservative PACs in Tennessee, as well as in other parts of the South. Nonetheless, perseverance produces results. Last year, we were able to get 2 small but very important policy changes here in the state. We did some modification to the criminal laws outlawing syringe possession as one step towards syringe exchange. We also modified one of our HIV criminal exposure laws, providing a way for sex workers who were convicted under those laws to have their lifetime registry as a sex offender removed. These are small but incremental changes, which in fact can make a real difference in people's lives. So, if you want to keep up on what's happening in Tennessee, here's the commercial. Join us by going to tnaids.org, sign up for our monthly e-newsletter and action alerts. Thank you.
Thanks, Joseph. Next, we'll invite Daphne Robinson from the Law Center at the University of Houston.
Thank you. Yes, that's very good.
How did we get the PowerPoint out?
It's right there.
Oh, good.
Let me just say, my name is Jacky Robinson, and I'm a lawyer, recovering lawyer, I like to tell people. And I've been in really deep detox because I was a prosecutor for 20 years. And so somewhere along the way, I decided I wanted to go back to public health school. I was getting a master's in public health in May after 3 years of program at Emory University as their executive MPH program. So that is one reason why I've delved into these issues of healthcare. So I am not the expert, but an interested passerby, I guess. And so the topic that I chose for today was living and dying in the Mississippi Delta, probably because I am a native of Greenville, Mississippi, which is located in the Mississippi Delta. And so I've learned and we've come to appreciate the social determinants of health. We know that there are certain inequalities that exist in our communities that contribute to poor health outcomes for individuals. The social determinants are defined by the World Health Organization as those conditions that exist in the places that we live and we grow and where we work and where we age. And so these circumstances are things that shape who we are. And they are shaped by money, power, politics, policy, global, national, at a local level as well. And so we know that place really does matter. It matters because of the quality of schools, access to medical care. Do we live in food deserts? Are there food insecurity issues? So there's my map. This is a map of the Mississippi Delta. I have seen this map on many of the maps that I have seen this afternoon because that area right along the left edge, or my left edge, says Bolivar, Rosedale, Greenville, Washington County. Those areas were all in red on every map that you saw just a little while ago. And so the Mississippi Delta includes DeSoto, Holmes County, Coahoma County, Carroll County, Bolivar, Humphreys, Esquina, LaFleur, Panola, Quitman County, Sharkey, Sunflower, Tallahatchie, Tate, Tunica, Warren, Washington, and Yazoo. The demographic profile of the area is that Mississippi Delta is, of course, primarily rural. There are 119 census tracts in the Mississippi Delta, and over half of those census tracts are considered rural. Access to care is, of course, a challenge because of the rural nature of the area. The fact that medical providers are more often located in the more urban centers, Greenville, where I'm from, Jackson, Mississippi. Limited access to healthy foods because of the food deserts that exist. The USDA defines a food desert as an area in which a low-income tract, census tract, where at least 33% of the population is more than 1 mile away from a supermarket or large grocery store. There are 34 census tracts in the Mississippi Delta that are considered food deserts. There's an increased exposure to environmental toxins in the area. There's limited housing, and the housing that's there is of poor quality. There are many homes that are still without plumbing in the area. The research talks about the diversity index. The Mississippi Delta is 60% African American. The diversity index says that the rank is from 0 to 100. The higher the number, the more diverse the area is. And so the Mississippi Delta has a ranking of 88.7, so you would believe that it's more likely a diverse area, but when you go into the public schools, you'll see some of the most segregated places still. Public schools are more often 100% or close to 100% black, and private schools are more likely 100% white, or as close to it as possible. Most families in the area fall below the federal poverty level, which is about $22,000 annually for a family of 4, and this is right here in our country. And so almost 40% of the population falls 150% below the poverty level. Families in the Mississippi Delta experience the third highest rate of food insecurity in the country at 17.4%. And nearly a third of the population in the Mississippi Delta, 25 years and older, has not completed high school. Nationally, Americans we know without a high school diploma are more than 3 times as likely to die before the age of 65. I guess I'll get to the meat of the matter. We know what the health outcomes are in the area, and they're quite poor. That between 1990 and 2008, the life expectancy varied by more than 10 years between the counties in the Mississippi Delta. The best one was 69.5 years, and that is in Tunica County, which is, which has improved because of casinos that are located in the area. But this life expectancy is still lower than the Dominican Republic, Estonia, and Sri Lanka. The mortality rate is 1.3 times higher than the average in the U.S. And so I decided to take on the premise of how do we deal with the health outcomes that exist in the Mississippi Delta. So much of it, of course, has to do with the racism, the institutional racism that exists and has existed in the community and in the state as a whole. And how do we harness the power that's in the community, the power of the people that are there. And one of the things that I suggest is that we implore the use of community health workers. This is a global talk, so we know that community health workers have been used all over the world to improve the health outcomes of communities where there is a strong cultural center where lots of people exist and are very distrustful of people that don't look like them. And the reason why this distrust exists in the community is, as I said, because of the historical context. Issues like the Tuskegee experiment, the Mississippi appendectomies, I don't know if any of you are familiar with those. Fannie Lou Hamer said that she was the one who coined the term Mississippi appendectomies, when women would be taken to the doctor thinking they were having an appendectomy and actually being sterilized. And so, as I ran away with my PowerPoint,
That's the wrong one.
yeah, I see. Well, I'll just tell you, because you asked me what do they talk, that the community health worker model is the model that I'm suggesting to be used more often in the Mississippi Delta to improve these outcomes. We're taking the model out from one that is a medical provider-centered one to one where community health workers are the individuals who go into the community, gain the trust of the individuals that are there, provide them with the resources that they need in order to defeat many of these social determinants of health. So I only have 2 minutes. Thank you.
So next up is Tara McKay from the Vanderbilt MHS assistant professor.
Yep.
All right, we're going to be taking you somewhere else. I'm actually one of the few people presenting today who doesn't work on the South, not even in the slightest risk. And I'm going to be talking about an organization that I've been working with in Malawi and trying to bring back some of the connections and lessons and maybe thoughts that we can use to just make some connections between the global South and the South in terms of how we study it, how we think about it, where we're going. So one of the things that I've been kind of looking at recently is issues of political homophobia in sub-Saharan Africa, so in countries like Uganda, in Nigeria, in Malawi, where political leaders are being particularly outspoken and negative towards sexual minorities and gender dissonance, and kind of making new laws that actually expand criminal penalties or create new criminal penalties for these populations. And in general, I want to kind of state, and I'll come back to this towards the end, that Western journalists kind of overstate this in terms of being the norm on the continent. It's happening in particular places with particular political leaders in particular contexts, right? And that's important to remember. But nonetheless, this can also severely limit LGBT organizing in these contexts, right? This is the kind of context that they have to engage with, navigate, and kind of work around. So one of the places that or the place I'm going to take you today is Malawi, where I do quite a lot of my work, which is in southeastern Africa, bordered by Tanzania, Mozambique, Zambia. To give you a frame of reference, and this is a country where same-sex sex has been criminalized basically since British rule, and these kind of laws were retained and ratified post-independence. And historically, very little LGBT activism has been taking place in this country for several reasons. And there's no like real visible, organized gay community for most of the time that I've been working there, which is since 2007. But one of the organizations that kind of has come up and been more visible and been able to kind of work on these issues is called the Center for the Development of the People. And they were formed by a small group of men, most of whom were self-identified as gay men, and most of whom were Malawian, so they were native, not a like, kind of international or like expat kind of organization. And they really kind of started in order to try and bring some of these issues of sexual orientation, discrimination, and gay rights to the fore of Malawian kind of politics, and at least provide some services. Now, one of the things that has to happen in this kind of context is these organizations have to kind of actively manage their visibility to government officials, right? So this organization actually, in order to be registered, in order to get funds from other places, even from international donors, has to actually go through a government process of approval, right? And so when you're in a state or a country where same-sex sex is criminalized, you can't just say this is a gay organization, right, in the title. So you can even look at their seal here, and it's kind of small, but there's like a little African family with a child, hetero, right, looking, and we have this kind of disguised language of the Center for the Development of the People. What could that possibly be? Like, it's so generic. In order to pass through these rigors of the kind of government process of authorizing NGOs, right? Another thing that's kind of characterizes organizations in these countries, especially working with LGBT populations, is that they are highly unstable in terms of resources, right? So they have very infrequent access to support, certainly from within the state, but also from international donors. And what that means is that their priorities, no matter what they kind of developed in order to address, tend to also try and figure in how donors want them to be responding in an environment. So this organization that I mentioned set up initially started in order to think about sexual diversity in Malawi, but ultimately, because of funding that's kind of available and the issues that are at hand in 2006 and 2007, ends up kind of completely, like 95% of what they do is about HIV/AIDS, right? So they become this very public health-oriented organization, right? Even though their initial goals were kind of social justice-oriented. Now, in sociology, there's kind of a debate about organizations in terms of what they do, if they side with public health and kind of depoliticize, or if they maintain their social justice interests in the absence of kind of serving the public health or kind of social needs of their constituents, right? We're not going to go into that debate too much, because I want to tell you more about the organization, and also because I have 7 minutes. But what ends up happening is they start to kind of they do that public health for like 5 years, right? But they start to have this kind of challenge, right? In late 2009, in early 2010. So I did a lot of fieldwork here during this time. What happened was a cisgender male, Stephen Mujeza, and a transgender female, Tiwange Chimalanga, were arrested in late 2009 for essentially having an engagement ceremony. On suspicion of violating the country's anti-sodomy law, right? So they go through a court hearing, and what ends up happening is set up this organization that I'm talking about is the only organization that's even remotely interested in LGBT issues. And so what happens is they become the de facto support for the defendants in this case. And they also become the kind of international contact for Amnesty, for the International Gay and Lesbian Association, for Human Rights Watch, in order to figure out what's happening in the country around this case at that time, right? They are in the media all the time, which is a very new role for them, right? And they kind of wanted to go back to this depoliticized public health work, but they also kind of after the trial, felt like there was something here, right? There was something worth continuing, and they started on these kind of new social justice projects. So they participated and organized in these mass protests that happened in Malawi, basically the biggest protests that have happened since the independence protests in the 60s. And these were protesting government abuses of power and corruption. They weren't protesting sexual rights or gay rights or these kinds of things. But this organization was kind of integral in trying to get this movement organized and started, and even tried to kind of incorporate their message in the movement garb, right, their t-shirts, right? And they also kind of engaged in more coalition building with other rights groups, which improved their stability on the ground. It created some folks with other stakeholders, right, that weren't going to allow the government to just kind of quash little organizations. They were now kind of much stronger. And ultimately, they were able to, through these coalitions, build LGBT rights into some of these other campaigns on women's and children's rights, on HIV treatment access, and so on. So kind of bring it back to the South with the disclaimer that I am not from here. I'm kind of recently transplanted here, and also don't study the South. I think there are still some things that I can kind of take away, right? In prepping for this, read my paper and say, oh, all of these things that I say about Africa are things that I can say about here for the most part, right? And some of these things are that we tend to see Africa and Africans, as well as, I think, the South and Southerners, as this monolithic group that is associated with homophobia, right? So we see blackness and Africanness as homophobic on the one hand, on the African continent, right? On this side of the Atlantic, we associate this intersection of whiteness, southernness, and sometimes poverty with homophobia in ways that are not necessarily productive, right? They limit our ability to identify possible coalition members, to kind of appreciate the diversity of opinions, that kind of overemphasizes extreme minority views, and also underestimates the diversity that's inherent here. This is a graph from the Williams Institute showing you actually diversity among southern states as well as change over time. Right? I see this also happening in Malawi where I work, this change over time in attitudes towards homosexuality. And then final connection, right? The other final connection is that there's also a lesson here, I think, for organizations. So Malawian organizations tend to get most of their support internationally, which tends to drive their priorities away from constituent interests, right, the beneficiaries that they serve. And I think this also happens in the U.S. And seems likely to happen in for southern organizations that have to rely on bigger national organizations for intellectual or funding kind of support, organizations that are elsewhere. And might dominate priority setting or overshadow more local interests or needs. So perhaps as the political environment changes here, based on that previous graph, not on the government legislation that we've seen many times here, maybe there might be new opportunities to incorporate Southern issues or concerns into LGBT activism. I think Gilbert Gonzalez previously gave you a nice list of several options here, and Joe's talk gave you several related to HIV that might be of concern. One of these that hasn't come up yet is related to this map, which is depicts the CDC's 2015 decision, which happened late last year, basically where they decided not to fund HIV community organizations in rural areas. Well, this disproportionately affects the South, where in some states here, Alabama, Mississippi, South Carolina, and North Carolina, 60 to 70% of people with HIV who need services, who are going to work through community organizations, don't have access. They live in rural areas, and these places aren't going to be funded, right? So there are several other issues that might come up, but these seem like some to get started. Thank you.
Our final speaker is Beth Conklin, the Department of Anthropology at Vanderbilt.
people are thinking
I guess not.
they're outside of metropolitan areas, but it turns out, for example, in North Carolina, it's not rural, it's in cities. And you can see them all clustered, so it's not Charlotte, Raleigh, Durham, Nashville, all these places, which still are, people are included in that.
Do you have it on USB?
And it's interesting. The reason I live in Louisiana for 20 years. So, of course, we just Medicaid Expansion.
Well, there's a colleague of our Southern Age Coalition, and I can't even care if I say if I look at it, let's say, have all these people who got insurance who are going to have to drop their insurance and be involved in Medicaid because Medicaid is terrible at resort.
I think we're okay.
Yep, she's got him.
Central health benefits packages that they were getting under insurance.
Wow.
They do these issues about.
That's right. Hey, just talk.
She sent me a slide. She said, I just think that it was so bad. They're like 32. So this, but they're all
So to look at what climate change means for public health in the Southeast, I want to begin with this quote from Jim Hansen. He was the US government's top climate scientist until he resigned in protest against the Bush administration's attempts to control NASA's dissemination of public information from scientists studying climate change. So why did Hansen single out the South as the region's most vulnerable to harm from climate change? There are some obvious answers. It's obviously already hot here a lot of the time, and some less obvious answers related to the distinctive social and environmental conditions of the South. The first obvious factor is that the Southeast has more seacoast and islands and more miles of rivers than any other part of the country. I apologize for the blurriness of some of these slides. This was a cover from Rolling Stone. Miami, which has already seen an unprecedented amount of flooding on a regular basis, gives us a preview of how rising sea levels may affect the millions of people who live near the Atlantic Ocean and Gulf of Mexico. Many of the most serious public health threats involve flooding, municipal water supplies, and energy. Katrina and the devastation of New Orleans put the question of how global warming may intensify storms and seawater surges into our national conversation. Nashville had its own encounter with flooding in 2010 when much of downtown and neighborhoods in Bordeaux, Bellevue, and Antioch were underwater. You may recognize Charlotte Avenue here. Many of us remember the city underwater in 2010. But it's easy to forget how close we came to losing our entire municipal water system. Nashville has 2 water treatment plants. One was flooded and completely out of commission. And the Cumberland River was within a foot of flooding the other one, and the river was still rising. This would have left the entire city without any drinking water. We were saved by prisoners from the county correctional facility in Antioch, who did heroic work sandbagging, many of them working as long as 36 hours straight, and they essentially saved us from what would have been a huge public health crisis. Flint, Michigan now reminds us of how critical water is as the bedrock of public health. Besides the threat of flooding and storms, there's the public health challenge of heat waves. Heat is already the #1 weather-related killer in the United States. Heat waves are deadliest for the elderly and for outdoor workers. In the South, large numbers of people work outdoors in construction, agriculture, utilities, or manufacturing. In Tennessee, almost 1/3 of all employees work outdoors. Many of these workers who are especially at risk are Hispanic immigrants. The Southeast is also the highest energy user of any region in the US. The need for energy for air conditioning skyrockets during heat waves, but heat and drought themselves reduce energy generation capacities. TVA's nuclear plants are cooled, TVA's nuclear plants are, are cooled by river water, which can't exceed 90 degrees Fahrenheit. In the 2010 heat wave, the Browns Ferry plant had to power down to only 50% capacity because the Tennessee River was so warm. The same thing has happened during heat waves in France, which gets 75% of its electricity from nuclear, and in Spain and Germany, where nuclear plants have had to shut down during various heat waves. Then there are the many ways that a warming climate affects non-human life: insects, microbes, plants, and molds. With warmer temperatures expanding insects' range, mosquito-borne diseases like Zika, malaria, and dengue fever, and tick-borne infections like Lyme disease may increasingly be in our future. Bacteria, viruses, and other pathogens that thrive on warmth may be a factor already in the increasing cases of food poisoning. For example, for every degree that air temperature rises above 43 degrees Fahrenheit, salmonella cases rise 12%. And cyanobacteria, toxic blue-green algae blooms, are a threat to people, pets, livestock, and wildlife, causing severe nausea, vomiting, diarrhea, skin rashes, and potentially death from liver failure. But probably the biggest and most immediate way that Southerners will experience climate change is with asthma. Ground-level ozone and soot contribute directly to global warming, and methane, one of the most important greenhouse gases, is a major cause of increased ground-level ozone. The warming climate gives pollen-producing plants a longer growing season and creates more hospitable conditions for mold to grow indoors. Children, the elderly, and people living in urban heat islands will be most at risk. The effects of ozone smog are concentrated near interstates and busy highways, which is often where poor neighborhoods and public housing projects like the Casey Homes in East Nashville are located. Asthma attacks and heat stroke are acute conditions that require immediate medical care. And here we run up against another distinctive feature of the South, which is the vulnerability of rural communities. In contrast to other parts of the country, the South has more rural communities of people of color and the greatest shortage of primary health care providers in rural areas. A recent survey of African American physicians who care for a disproportionate number of African American patients found that 61% of the physicians said they are already seeing harms from climate change among their patients. Respiratory problems and increases in chronic diseases exacerbated by air pollution top the list. So this is a very quick and, I'm afraid, rather depressing survey of the broad range of public health problems that climate change will bring to the Southeast. On a more positive note, we can note that we already know that these problems are coming, and they're very much in our hands to try to solve.
So we'll take questions, maybe a couple of questions, so that we can have maximum amount of time for respondents. Who would like to open up? Dominique?
Sorry. No, but.
Okay, please.
I'm an elderly physician trained, that grew up in the South, trained in the South. This has been a very important meeting for me with parts of it. But what it seems like we're left with are two Americas, one that took Medicaid expansion and one that didn't, but also climate change affects us all. What do you do, or what are we supposed to do in a country where half of the political party, one political party, denies the facts and signs of climate change and rejects expansion of Medicaid?
Easy one. Who would like to speak?
You vote.
Change the party is right. You vote. I lived in Louisiana, and the governor.
Do you want to use the mic? I don't know if we need the mic.
And the governor in Louisiana just moved to change or to expand Medicaid.
Yeah.
And so, and he's a Democratic governor, as opposed to Jindal, who was not. And so, I think it's going to be incumbent upon people to get involved in the process, to advocate. I was at a meeting recently in Texas where there were business leaders in the audience, and they talked about how this was important to them, and how do we make it comfortable for legislators to do this. So it's going to take all of us being engaged in the process.
Yeah. Small incremental steps is sort of the way that happens, and you keep working. I mean, there's a large coalition. We were working for at least 2 years here in Tennessee, and we're going to keep working. And, you know, in a legislature which is opposed to basically all things Obama. I mean, that's basically it. Speaking of a conference in which there's the intersection of race with politics and everything else. And the mantra at this point is after the election, after the election. And we're hoping, you know, either after the election it's going to be really bad because we're going to have a president who's going to block grant repeal the ACA and block grant Medicaid, and then we're really going to be scrambling. Or we're going to have a president where they're basically going to say, you know, it's done and we should go back to Medicaid expansion because there's nothing we can do about it that's going to happen. You know? So I'm back to the original statement, which is vote.
Tara or Beth, have anything they want to add? No? Yes, please.
So I guess it looks at a new intersection of education and poverty, right? So how can we reach these people who are in poverty that are voting against their own best interests, educate them, and then even reaching the ones in the rural spaces, as you mentioned, with all that space between. Yeah. How do we reach them and educate them so that they then do go and vote for themselves?
Yeah. You know.
I think there might be some important assumptions to address, basically, what you just said too, is just that some people are excluded from voting pretty systematically in a lot of these states, so addressing some of those issues seems really important. Like if you're in one of these states that has 5 DMVs and you need a driver's license to vote, like that's not a, like that's creating a huge barrier. So the legislature and the representatives are not representing the public's interests, they're representing a very particular set of interests of people who are able to vote. And so thinking about those kinds of issues also seems to make sense, and also approaching some of the people who do vote and seem to be voting against their self-interest, like with some level of understanding and trying to figure out like how that actually is their self-interest or like what they imagine their self-interest to be, seems to be one of those things where we need to kind of be a little more flexible and allow people to kind of tell us why they're voting that particular way, like their kind of alienation from the Democratic Party, for example, or feeling judged by Northerners and coastal people that don't take their issues seriously or don't want to like actually engage or hang out with them, right? These kinds of issues. So I think there might be some other places to poke that.
I mean, one of the things we're doing in HIV advocacy is I think a lot of us, including our advocacy network, are now moving into doing voter education and mobilization, first of all, because people need, and part of that education is why it makes a difference, because I think that there also is this sense of fatalism in terms of like things are so crazy that what is my vote going to do? And it does do something. But that also includes information about specific, for in Tennessee, for example. So what's the voter registration and the ID laws? What do they say? What do they don't say? What kind of IDs can you use? How do you get a hold of one of those IDs? It really needs to provide that sort of hands-on information to help empower people to actually get the tools that they need so they won't be barred from voting. And you know, that's certainly one step in that process. I think I would agree with the other issue that I think that it's easy to dismiss why people are voting, and I mean, it's ever since the What's the Matter with Kansas about people voting against their best interests, which is certainly true, but there is a certain appeal. There's a reason down there, and one of the interesting discussions that's now moving around, for example, the whole Trump issue is, the challenge is that there is a real anxiety around the loss of jobs that lies at the bottom of all of this xenophobia and racism and everything else. And we ignore that anxiety and that reality that's been occurring for more than a decade at our peril because it's a real experience. And so we need to confront that, and we need to grab the terms of that discussion and move it so that people don't end up vote for somebody else who can actually resolve those issues.
Any other questions from the floor? I think Dominique, you're patient. Does anybody else have a question? Maybe Dominique, you want to?
I think I'm okay.
You're okay?
I've been, or I have, should I?
We have time.
Okay, good. Wait, time. I don't know what time it is.
Yeah, you taskmaster.
I taskmaster.
It's 4:17.
We're supposed to be having
over.
drinks at 4:15. I was very intrigued by Tara's case study of this kind of grassroots mobilization that cut across, you know, a lot of what we would conceive here to be really hard to break down barriers in terms of grassroots organizing. So I wanted to know a little bit more about how that happened, but also ask maybe the other panelists to comment on the learning experiences that might bring here. Was it a case of there being a vacuum of activism, point blank, and so they're just filling this space that includes everyone, or was there a more concerted, organized philosophy behind it?
Sorry. Thank you. Well, so they started small, and they also they were trying to. There wasn't a group kind of before them earlier in the decade. There was a group trying to actually change the penal code and work in this social justice framework, and actually try to take away the criminalization of same-sex sex part of the penal code, and that ultimately failed miserably. They were thrown out of parliament. And so I think this organization kind of learned from that a little bit, we need to be a little bit less visible. We need to kind of make claims or demands that are going to fit with what's happening in the current context. And so that's part of why HIV kind of became one of their primary issues, because to be an HIV organization in 2005 and 2006 and 2007 in Malawi was to be one of hundreds, right? And so they kind of could fit in that particular way. But all the same, they were kind of the only organization doing that, and they were kind of ostracized by other organizations, a lot of whom were faith-based and didn't want anything to do with this. And so they had a real hard time initially kind of building coalitions and trying to make sense of what they were there to do and even how to do it, and had interruptions in funding and interruptions in their ability to practice until this post-trial phase when they just had a huge influx of support internationally. Certainly that kind of shifts their priorities a little bit too, right, in terms of what they're doing and how they're doing it. So there are consequences to that support.
Dr. Metzel.
I have a legal question. Is there culpability with all this? I mean, it's just so infuriating to see these maps. And of course it's the South has always had bad health and stuff like that. But now there's a policy treatment that will save people's lives. And we're not adopting it. And so, I mean, it seems like people should be held accountable.
Well, I mean, I agree with you. I mean, they should be, if there were laws in place in order to make that happen. I mean, a perfect example is gun control in this country, that the CDC was prevented from being able to study gun control because of whatever politics were going on at the time. But we know that with the research and the study, there will be more ways to find out how we deal with this epidemic of violence in our country. And so, you're right, I mean, more people should be held accountable. How we do that, I'm not quite sure, because there aren't the laws in place to put people in jail because we're not making people get the right kinds of treatment.
Can I ask a question? Go ahead.
The challenge we face in terms of that sort of stuff, and you were talking about PrEP, prevention, for example, we're advocating, but there's multiple levels. We're advocating A, on the very cost of the drug and what it's priced at, and B, on getting systems that are going to be able to provide access, because it's expensive under any terms, and how do people pay for it. But we're dealing in a system in which access to healthcare is to some degree informed by the profit motive in the United States, and that's in distinction to Canada, most Western industrial countries where that's not the driving factor, but that's what at this point we're dealt with. And I mean, Sanders is right when he says some of us advocated for single payer or at least a public option when the ACA was up for debate, and we lost that battle.
So that actually touches upon my question I was going to ask you guys. So my question was, seeing all these issues surrounding with health and health disparities and health inequities, whether it's through the environment or through HIV/AIDS or through activism with organizations throughout the world, do you see, are these issues that are happening right now in today's world, are these issues where we're going to have to be trailblazers in finding solutions, or are there sort of pre-existing solutions already in place? Do you have any sort of countries, organizations, or systems that you sort of see as role models for what the U.S. could adopt? Or and how do you see us actually proceeding from here on out? Because I feel like all these issues are so pertinent to all of us. But in the next 10 years, 20 years down the line, where can we go from here?
Who would like to take?
Well, I'll say as it relates to my original talk about community health workers, I mean, that's a model that's been used all over the world. But it's been used very little here, and particularly even less in the demographic of the Mississippi Delta. And so there are lots of models where it's working very effectively in African countries. So if we brought that model here and used it, and there are other healthcare models, but I do think that you're going to have to be the trailblazers. I mean, when you talked about education, that we're going to have to start younger now in order to get to people like yourselves who are sitting in the audience who are like-minded and understand what we need to do in this country. We're a lost cause, I think.
Okay, just a quick question about exceptionalism. I think Joey brought that up, and I've been trying to think about that in the context of HIV as the kind of the end of exceptionalism has also meant the end of sort of an exceptional response to HIV that came from the HIV/AIDS community. I think sometimes when we want to talk about integration across services, across concerns, I think some of the exceptionalism is actually good. And sort of in the case of the South, maybe there's an exceptional civil society response that you lose when you try to work across divisions and just.
Well, the response, yes, we developed. I mean, sometimes the way we phrase it is, we were lucky enough because we advocated and got some specific streams of funding that we were able to develop what we call the gold system, of a community system of care. But the solution to that is not to let that wither away as we integrate into mainstream, but to bring everybody else and other disease conditions up to that standard. And currently, the way that public health systems and the systems of paying for that are constructed, we don't have the resources to do that. But that's what we should insist upon as our goal and our standard, and not settle for less. And I think it does mean, to some degree, a combination of both. There are models out there, but as that evidence about the South, the way we phrase it is one size doesn't fit all. It's going to have to be adapted to deal with local community needs and circumstances. And we need to support that.
Do you think we should look to Canada?
For some things. For some things. Yeah. But Canada's going to build a wall to keep the rest of us out, depending on what happens on the election. So
on behalf of Dominique and myself, I think we'll just want to thank the panelists for a really great closing panel, and we'll invite Dr. Benson. But thank you very much.
Okay, you guys can, we're going to stay up here, we're going to do a closing conversation, or you can sit back down in the audience, whatever you're doing. We're going to conclude with just 5 minutes. I really just have 2 questions for the audience before we break. First, let me just give everyone a big round of applause. You've all done a great job here. Thank everybody. We're going to go to the reception here in about 5 minutes. Let me just ask two questions. One is, what did we learn about the politics of health in the South? I guess partially it's like, what did we learn that we didn't know at the beginning of this conference, or what themes cut across some of the panels? Was there anything that surprised people or seemed to flow through? Or I mean, I guess I was thinking that we started off with this map, a map that looked kind of like this, but it was like poor health outcomes. And so did we add nuance to that? So what surprised people, or was something that jumped out at people about what we learned about the South? Please.
I'm surprised that some of the graphs, this one obviously includes West Virginia, which in some ways is the quintessential South, though it does stick up there in the north. I think it was Conklin's presentation had the South, and that little indentation omitted West Virginia, and then I believe the previous presentation cut off Kentucky, Virginia, Arkansas, Missouri. I mean, it had
different definitions.
So I'm just curious there. That's sorry. Go ahead. Forget it.
We often use the official definition from the Centers for Disease Control, which is, what is it, 17 states. It goes all the way up to Maryland and Delaware, and Washington, D.C., and then around into Texas. And so some of us look at that and sort of say, Florida, Texas and Florida, which actually have large numbers that contribute to disproportionate impact, are not the South. They're not out of that.
Please.
Keep West Virginia in the South.
We'll do that.
I think we can all agree here that in the South there's a lot of disparate inequities and inherent inequities in access to healthcare, but also equality of healthcare. But I find it pretty amazing that with all of this information, nothing as of yet has been done to sort of rectify that or to even address that through the government. Like, you think in places that need it most or places that have affected the most aid would go to that, and it's like you don't see that, because it's like in terms of there being lots of inequities, at the same time there's like ACA is not expanding, and it's like crazy things like that where it's like it's very ironic, and it's just crazy.
Crazy. That's why I was asking about co-ability. It's almost, we're making policy decisions that have very profound biological consequences for people. Not making policy.
And I would say, just in tying together the theme of the conference being politics, race, and health, how our politics in this country has really been so entrenched in the idea of race and that construct, and how people's identities are based upon that, which informs how they vote in the politics and the constituents, and how they write policies and create laws and rules and the constraints in which we live, which leads to these health inequities and health disparities, whether it be constant stress and leading to low birth rate babies, or just food deserts, and just that whole health disparities that we as biomedical scientists study and try to we talk about every time. We want to decrease health disparities, but it's so entrenched in the politics and the racial identity of politics that it's something that is truly interdisciplinary, and we need to begin. I think the revolutionary fact, or really the trailblazing fact, is that our generation, whatever we're called, we have to really put our hands around this idea of racial politics and racial identity, and really uproot some of that, so that it's not that superior inferiority thing anymore, like it's historically been, but reject that and go forward with a new idea of what it means to be an American.
Sure. Anybody learn anything about the South that they didn't already know? Jumped out at you as surprising? Please.
Yesterday, I think what was new that I learned from, and I'm trying to look at the person, was it Consuelo?
Yeah.
She was talking about just the level of funding, or the lack of funding that occurs in the South on these very kinds of questions, and how if you look at the distribution of funding, maybe she was looking at the NIH, I can't remember, and how, so how do you solve, understand the problem, understand the complexities of the problem, and then try to design some of these more complex ways of thinking about how, the history and the structure are all affecting across the board these inequalities, that with these patterns, these maps over, no matter how you define the South, we see these segregations. So, to me that was very, very political, right? Very, very interesting to think about living in the South and doing this kind of research. So these decisions on, what knowledge matters, right?
And Michael, please.
Yeah, just from a Canadian, not knowing anything about the South.
Please save us.
I guess I've been paying attention and being really concerned about the way in which we present health problems as being endemic, and kind of contributing to a pathologization of people who live here. Again, I don't live here, only for 5 months, and I just think, coming from a context in which we talk about Indigenous people in Canada, they've been really good about sort of focusing our attention on how our models, our maps, our graphs also make the problem so intractable, and almost make the point that being Indigenous is a problem, like being a Southerner is a problem. So I don't know what to do with that, but it's, that's it, sorry.
Yeah, no, and also that many of the health sequelae that we see themselves are not Indigenous. They're the result of specific decisions that we make that then have profound implications. Now, this conference, and Adam and I have been tweeting about this a little bit, and part of what we've done, so it's like, is the answer a political answer, a policy answer? And we've very consciously in this conference, and no surprise, we've tried to bring together activists and theorists and lyricists and policy people. And so partially, I think, everybody in this room probably had a moment of one talk or another where they thought, well, we have very different evidentiary claims. And so part of what, I think one of the assumptions built into this conference is that we can form coalitions cross-disciplinarily, even if, sometimes you think, oh, you're trying to make a policy claim, but you're using literary evidence or something like that. So the question is kind of moving forward, are those coalitions helpful, useful, or frustrating? That was a kind of framing question, but did you have a question over there?
Yeah, I guess I just wanted to add, there's this question that's been raised, I think, every couple of presentations of what is the role of non-Southerners in the South in the process of change? And I mean, I guess I just want to contribute the suggestion that the South will only be transformed by Southerners.
Which we all are now.
Right, and
but
in the sense of, with the recognition of it also won't happen without some of the broader alliances, because we can see from Southern history that we've been talking about populations of the South as in terms of their own sort of internal oppressions and colonizations. We can also see those same elites that are bringing that about in the South, expanding out some of these same models, whether it's HCA and its role in the United States in terms of health privatization, or CCA, based out of Nashville, in private prison privatization, or what the speaker was talking about this morning, of chickenization and how it's returning to the Midwest. Or here in Nashville, some of the evangelical broadcasters that are designing and exporting some of the homophobic laws to East Africa, basing those decisions on elite conversations that are occurring here in Nashville and in places like Nashville.
I think that's a great point, actually. I mean, Julie, I was going to add that.
Go ahead.
Wait. Because I work on gun policy, right? And the question is the South a region that needs to be saved, or are we an incubator for particular politics? I'm actually, believe it or not, going to the occupied territories next week, and Beersheba and the occupied territories, because the NRA is making a push there for concealed carry using our model. And so in a way, this is like, oh my God, what's happening? But so in a way, it's like, is this spreading, or is it, in that particular way? And I think that there's a real issue right now, which is why this election is so important.
I just wanted to respond to your question about interdisciplinarity
Please.
and different approaches. And one of the things that struck me in these 2 days was, and especially in the readings from Jessamine Ward and Tony Early, is like thinking about Southern literature and how it really embraces and discusses violence, poverty, increasingly race, but yet our politics do not in the South. And so I think that if we can involve Southern literature in our approach to these, that it gives us a language. We're saying we're already dealing with this in our literature and our art, and how can we think in it? And so responding to these things politically is also Southern, right? We have that history.
Can I just make a plug based on something Julie said? So some of you maybe have already heard this announcement, but on Sunday, for those of you who will be in Nashville or live in Nashville, we're doing a screening of a film, a documentary called Trapped. It's being generously sponsored by MHS, but also the Cinema Media Arts program and the Women and Gender Studies program here at Vanderbilt. And I mention this in this moment because this documentary is such an interesting and powerful example about the way that art and culture and politics and lived experience and activism come together. So this is a documentary called Trapped by Dawn Porter, and it is a documentary about trap laws and their particular implications for U.S. states in the South that target reproductive health options for women, and looking at the way that the dismantling of abortion service providers in a lot of southern states is affecting women, and in particular affecting women of color and poor women of color, and women who are poor in general. So the screening is free and open to the public. It's Sunday night, 7:30 in Surratt Cinema. And we're really lucky as well to have one of the consulting producers for the film is going to come and do a Q&A following the screening and talk about the experience of getting the film made. It just premiered at Sundance in January, and it's gotten really great reviews. and it's going to air for the first time on PBS in June. So it's very exciting that we get to see this film now, when the legal battle around the trap laws and around health, reproductive health for women is being fought on the front line. So I've got some promotional materials if anybody wants it. But again, the film is Sunday night, 7:30 in Surratt. It's called Trapped, and it's directed by Tom Porter.
We just have time for a few more comments, and part of the comment is what we're talking about, so we'll do that, but it's also what next steps, if anybody has any thoughts about, I mean, we've tried to start a conversation here, but where do we, what next step should we take in building what we've started?
So one thing I've been thinking about all of these things is that just as we're seeing in this election that we're not post-racial, I think the South has to just own up to the fact it's not post-Confederate, right? It is still the Confederate South, despite how we want to think about it. And you think about what was happening in the antebellum periods, where the source of this economics was this workforce that they had for them, right? Where there was wealth in the South, and maybe wasn't all poverty like we're seeing in some of these reports today. And I'm not, maybe I could be wrong about that also. But I think about when apartheid ended in South Africa, and I do some work over there, but some of these massive landowners, or they now had to leave, or they had to refine a new business model because they couldn't use the cheap labor they were doing before. And not everyone, because there's a lot of disparity there too. But I think if we just are truthful about it, it's the Confederate South, and then try to work that into the conversation, because it's segregated. There are people who are still mad about the war. There are people who would like to return to those days. And that continues to be this internal struggle that people just don't want to talk about. I don't know.
Final comment. Yeah.
Yeah, so I just noticed something. So I noticed that there is rural and urban medicine, and there's also like medicine for underserved communities and minority groups. So just in terms of like connotation and denotations, do you think that there's a distinction in the way that we approach each type of medicine, and do you think that it may influence how resources are allocated? I don't know if this makes sense.
It makes total sense. It makes total sense. I think a lot of talks in this conference supported that point, right? That it's not just rural and rural. It's like not everybody in the South has a lower lifespan, and there are very specific economic, socioeconomic, racial, historical reasons for that. So anyway, two more comments. Let's stack them.
One of the comments I wanted to make was that in some ways I feel like once the president leaves that we will return to the era of Jim Crow. Because, when I think about the advances that the country has made in this period of time, it's been sort of like Reconstruction, and that the next period will be Jim Crow. That's just my idea. And then my second point is that maybe for the next conference, you move the dial and you start talking specifically about what policies are working in what areas, and make that the focus.
More, what policies are working? So make it more.
Right, more upstream.
Uplifting.
Yeah, it was very dark. I think that's maybe one thing that surprised me was the way that Liz Harris-Perry's tone of her talk was a little darker than what I'd seen her do before. But in terms of thinking forward to the future, I think one thing that has been striking to me is that, it would be great to kind of continue these conversations. Sometimes in Atlanta, we can feel like we're the only ones talking about Medicaid expansion. And everybody here is talking about Medicaid expansion, right? And so, it would be great to have a stronger network across the South so that when y'all are in Atlanta, hang out with us and tell us more about what's going on, we can continue these conversations.
Sure.
Not only across Wake Forest and here, which has been an excellent kind of network, but more broadly.
Please.
Just commenting on the graphs that we've seen, it's troubling how obviously these graphs relate so much to graphs from the Civil War and slavery, and just how sad it is that 150, 200 years later, we're still sitting here with the same graphs.
Yeah.
And just how troubling it is that the front runner in one of the political parties, the slogan is "Make America Great Again," alluding to the fact that it has been great in the past, and just how troubling that is that we're trying to get away from these graphs, not back to them.
Yeah, it's important. Please.
So I have two comments. I think if the next time there's something that I thought was missing, there were two things. One was, I think that what we've clearly seen is that we pass on our structural inequalities to the lowest rung of society, and that a lot of the data we've seen wasn't even accounting for immigrant populations that are not necessarily citizens or legally in the country, but they're a group of people that are growing in the South, and obviously their voices are not even being close to heard. And so I think that we should try our best to get data on that respect. And the other thing is, many of the presentations we saw today brought up culture and identity broadly, but they didn't really dive into how identity or culture were playing into individual lives. And I would like to see more elements of cultural sociology or elements of psychology that play into these internalization of, I mean, the buzzword was intersectionality for a lot of it, but how much are we internalizing these disparities and discriminatory practices that we see broadly in society?
Which links back to Melissa's. Final comment.
I think it's interesting because I think this conference kind of highlighted in a sense that the South almost seems to be what Malcolm Gladwell points out as a tipping point. 10 years ago we wouldn't have talked so much about HIV or LGBT communities and all that stuff, and then we had this huge election coming up that's definitely going to affect the South, and the South has kind of said where they stand, but then there's people in the South that are like, no, that's not actually where we stand, and so it almost highlights the fact that the South is at this tipping point where we can be a forefront for change. We can really be a leader in a lot of research because we have a lot of poverty issues and racial issues, or we can almost fall back into what we come from. So I think that's a very...
I totally agree. This is a vitally important moment for this conversation and for this conference. So let's go have a party, everybody. Solve the problems over